So today we have a very interesting topic, is one of the most interesting topics as pertains to DCB, which is the bailout stenting. We need to understand when to do bailout stenting and how to do, and which is the outcome. And this is why we invited Mauro. Mauro Gitto is working at Humanitas Research Hospital with Antonio Colombo, with Bernard Reimers, and with Gabriele Gasparini, all good and dated friends and collaborators with many projects. And Mauro presented a few days ago a very important late-breaking clinical trial on DCB on the performance of bailout stenting. So thank you, Mauro, for joining us today. So the program will be, I think, with Filippo, we'll start presenting, some data on the background of bailout stenting, and then Mauro will present this late-breaking trial. As usual, the conversation is open. Unfortunately, I have to step out in a few minutes because I have another meeting here. I'm not in my hospital, but I hope that, as usual, this conversation is open, frank, and also quite interactive. So, Filippo, if you want to start.
Yes. Can you see my screen?
Yes.
Okay. Hi, everyone. It's a pleasure to discuss today about bailout stenting, also with our friend Mauro Gitto. Thank you, Mauro, for joining our meeting. I start with a brief introduction on bailout stenting, focusing on clinical indications, incidence, predictors, and prognosis. As you well know, percutaneous coronary intervention with drug-coated balloons involves the delivery of an antiproliferative agent directly to the coronary vessel wall without deployment of permanent implantation of metallic struts and polymer coatings. However, in a non-negligible proportion of patients, an additional stent placement following DCB angioplasty, a strategy commonly known as bailout stenting after DCB, is required in order to optimize PCR results and, more importantly, improve patients' outcomes. According to the recent DCB Academic Research Consortium and the second report of the Asia-Pacific Consensus Group, there are two main indications underpinning bailout stenting. First, to treat iatrogenic complications, such as flow-limiting target lesion dissection associated with a post-procedural TIMI flow less than grade 3, or high-grade coronary dissections, defined as dissection of type CF, or in case of ineffective balloon dilations due to significant residual stenosis and/or vessel elastic recoil. In the first studies focused on revascularization of small vessel disease, the rate of bailout stenting was very high, reaching nearly 35% in the Piccoletto trial and 20% in the Bello trial. Conversely, in more recent randomized and observational studies, the rate of bailout stenting has been dramatically reduced, accounting, for example, nearly 9% in the re-cage-free 1 trial, 7% in the Piccoletto 2 trial, and nearly 4% in the DCB BIF trial. Several factors may explain these findings. First of all, we use currently in clinical practice higher performing balloons. Second, there is a growing awareness of the clinical relevance of lesion preparation. Indeed, meticulous lesion preparation, often using special balloons and debulking strategies, facilitates drug penetration into the target lesion, thereby reducing the occurrence of vessel elastic recoil, while providing greater lead lumen enlargement and potentially improving clinical outcomes. Third, there is a large body of evidence that supports the safety of leaving non-flow limiting dissection untreated, thereby reducing the need of bailout stenting. What about predictors of bailout stenting? There is a paucity of data in current literature. This interesting study by Gabriele Ghetti and colleagues has been published 2 years ago on CCI journals and included a total of 168 patients treated with paclitaxel-coated balloon angioplasty. In this study, the rate of bailout stenting was quite high, nearly 14%, mostly due to high-grade coronary dissection, 28 of 30 cases. Of interest, the authors explore anatomical and procedural features associated with bailout stenting, and they found that vessel tortuosity, as well as revascularization of small vessel disease without a clear landing zone, complex target lesion, and a large DCB to artery ratio emerged as positive independent predictors of bailout stenting. Specifically, for each 0.1% incremental, 0.1 incremental in the DCB to artery ratio, more than 1, was associated with a nearly 4 times higher risk of bailout stenting. Our sub-analysis of the Eastbourne, prospective, multi-center, investigator-initiated, real-world all-comer studies, included more than 2,000 of patients treated with the Magic Touch sirolimus-coated balloon across 30 centers in Europe and Asia. In a per-lesion analysis, nearly 7.9% of lesions require bailout stenting, and in the multivariable logistic regression analysis, we found that de novo lesion, as expected, and smoking habit were positive predictor of bailout stenting, while the balloon inflation time, expressed as a continuous variable, emerged as an independent negative predictor of bailout stenting. In another sub-analysis of the Eastbourne study, we found a positive association between prolonged balloon inflation times and better angiographic outcomes, as demonstrated by a lower rate of coronary dissection and a higher TIMI flow grade 3 at the end of the procedure. And probably, from a mechanistic point of view, prolonged balloon inflations may induce a scaffolding effect, favoring vessel healing and thereby minimizing the risk of major dissections. What are the major concerns associated with bailout stenting? First of all, stent implantations compromising a leaving nothing behind strategy, thereby preventing the preservation of coronary vasomotion and potentially increasing long-term coronary inflammation. Second, there are safety concerns related to the use of higher doses of antiproliferative agents and a combination of different anti-restenotic agents such as paclitaxel and sirolimus. Mechanistically, this may lead to delayed reendothelialization and impaired vascular healing, thereby increasing the risk of stent restenosis and stent thrombosis. Third, bailout stenting requires a prolonged dual antiplatelet therapy, and this may pose several concerns about bleeding complication, especially for patients at high bleeding risk. And in the last years, several experiences demonstrated the safety and efficacy of short antiplatelet therapy and even single antiplatelet therapy after DCB in patients at high bleeding risk. What about the prognostic data? In the BAST small 2 trial, the patients requiring bailout stenting experienced a more than twofold higher incidence of MACE events at 1 year follow-up compared to patients treated only with DCB. In line, in the Piccoletto 2 trial, the incidence of MACE was more than twofold higher in the bailout stenting group compared to the DCB-only group. These 2 randomized trials included only patients with small vessel disease, and in the basket small 2 trial, a proportion of patients were treated with bare metal stents. Conversely, this single-arm study by Mitomo and colleagues included more than 100 patients treated with bailout stenting after DCB angioplasty, and this study demonstrated the effectiveness of bailout stenting in case of suboptimal DCB angioplasty results. Indeed, at 1 year, the rate of target lesion failure was relatively low, 4.3%, with no evidence of target vessel, myocardial infarction, and stent thrombosis. Of interest in this study, only 25% of lesions were small vessel disease. There was a high burden of complex lesion, and all bailout procedures were performed using the drug-eluting stents. In our sub-analysis of the Eastbourne study, the rate of target lesion revascularization at 2 years, the primary endpoint of the study, was 6.4% in overall population, and the two study groups, so patients treated with bailout stenting and with DCB only, experienced a similar rate of TLR as well as all the secondary endpoints, both in the unmatched and matched population. And these findings were consistent in specific subgroups such as those with large and small vessel disease, with de novo and ISR lesions. Of interest, in this recent analysis, we stratified patients from the Eastbourne study into two study groups according to the mechanism underpinning bailout stenting. And we found that patients requiring bailout stenting due to significant residual stenosis experienced a significantly higher incidence of TLR at 2 years compared to patients requiring bailout stenting due to severe target lesion dissection. And this finding is probably due to the not adequate lesion preparation in the residual stenosis group, and further underscored the clinical relevance of proper lesion preparation. From my point of view, there are two major gaps in knowledge actually on bailout stenting. There is a lack of real-world studies with larger sample sizes, and there is a lack of direct comparisons between bailout stenting following paclitaxel versus sirolimus-coated balloons. And I'm sure that Mauro will shed light on these topics very well now. So
yeah, great job, Filippo. Thank you. You did a very nice presentation on the background of bailout stenting with some initial, I would say, worries about the risk of that. You know, in the big solution trial, which will be presented at TCT this year, and that's going to be one of the two largest trials on DCB with the Magic Touch in the Transform 2, which is our trial. The rate of bailout stenting after DCB was very high at the beginning, and it was more than 25%. Then with the experience of the centers, it went down. And in the last patients enrolled, it went to 15 or 16%, if I remember well. So this is a very important topic, because if the physicians are not well accustomed to do DCB angioplasty, the rate is too high. So if the outcome is not that good as after DCB angioplasty alone, it can be an issue. So this is shedding light on the importance of good experience and expertise in using DCB, and on the educational activities that we all are doing after DCB. But now, Mauro, please tell us something about your findings in this big study.
Thank you very much, Filippo. I think that was really a great presentation, really introducing this important topic. Hope you can see my screen now.
Yes.
Can you see my slides? Okay, great.
Yes.
And it's exactly related to this presentation, this late-breaking presentation that I did a PCR a couple of days ago on this multi-center study, in which basically we tried to address one of the two gaps in knowledge that you, Filippo, were acknowledging in your last slide, which is the lack of large real-world experiences on the safety of doing bailout stenting after drug-coated balloon angioplasty. So I think it is very important when introducing the rationale behind this study to stress what Bernardo just said, that doing bailout stenting after drug-coated balloons is not what should happen, right? It's not the good clinical practice, it's not what we learn from our DCB masters when they teach us how to do DCB angioplasty. What everyone tells us is that you should achieve a good lesion preparation, first of all, then look at the result of lesion preparation. If the result is good, you do DCB. If the result is not good, you do stenting at that time point. So you should not be in the situation in which you do a DCB angioplasty and afterwards you change your mind because of a suboptimal angiographic result and place a stent. However, as Bernardo stressed, it happens. It happens in a proportion of cases in clinical practice, which is currently, before our study, was currently at 10% more or less in main randomized clinical trials, such as the REC-H3 and also in other large registries. And so there was a need, an important need, to demonstrate the safety of this approach, because it happens especially in less experienced centers at the first experiences with drug-coated balloons. And so in order to promote a wider adoption of the DCB technology, it was necessary to prove the safety of this approach. And the safety concern is the one related to the interaction between the anti-proliferative drug eluted by the stent, which is a Linus derivative, and the high-dose anti-proliferative agent eluted by the drug-coated balloon, which can be either sirolimus or paclitaxel based on the device. Because as you know, if these compounds on one side, they prevent restenosis, on the other hand, they might impair vascular healing and thereby potentially cause a stent failure in the long run if a stent is implanted. So on that background, we decided to design this international real-world registry evaluating the safety and the clinical outcomes of bailout DES implantation at 1 year after DCB angioplasty. And we decided to run it in 17 European centers, which were all, I have to say, quite experienced in DCB-based PCI. We included all-comer patients undergoing DCB-based PCI and receiving bailout drug-eluting stent implantation afterwards. As I said, on the other hand, we excluded those patients in which bailout stenting was done after lesion preparation, but before DCB angioplasty. And these were the main outcomes which we evaluated at the follow-up time point of 1 year. The primary endpoint was MACE, which we defined as the composite of target lesion revascularization, cardiac death, any myocardial infarction or stent thrombosis. And of course, we had target lesion failure and target vessel failure as the key secondary endpoints. When we designed this study and we were trying, of course, this was a retrospective study, this was a non-randomized study, but when we designed it, we wondered how many patients do we need in order to be statistically powered to test the safety of such approach. And for safety, we refer to an incidence of MACE, which was non-inferior to the expected performance goal for an upfront DS only strategy. So first of all, we wondered when DCB were supposed to be mainly used in the centers which were enrolled. And from our experience, from our clinical practice, DCBs are mainly used either in case of stent restenosis or in case of long and complex de novo lesions. I think none of the experienced DCB centers use DCBs for focal lesions on large de novo vessels. So based on that, we set this performance goal of 10.3% in terms of MACE at 1 year, which was taken as the main reference from the P38 study, which was a study in which, if I'm not wrong, Bernardo was also co-author, testing the clinical outcomes of the Science 38, so long stent and it demonstrated a MACE rate which was exactly 10.3% at 1 year. We set a non-inferiority margin of 3.5%, which is more or less the same as a relative 30% non-inferiority margin. And with these assumptions, we found that we calculated that a minimum sample size of 562 patients would have been needed to achieve at least 80% power, assuming a one-sided alpha of 0.05 and a 10% dropout rate. Of course, event rates were reported as Kaplan-Meier incidences at 1 year. We then evaluated predictors of MACE at 1 year within this cohort using multivariable stepwise Cox regression analysis. And as a key pre-specified subgroup analysis, we compared the outcomes of patients who received bailout stenting after paclitaxel versus sirolimus coated balloon angioplasty, and we did this analysis using propensity score adjustment for the covariates that are listed in here, which include the most important clinical and angiographic covariates. So this is what we ended up with in terms of study population. Out of more than 13,000 patients who received DCB-based PCI at the 17 enrolling centers between 2011 and 2024, we had 733 patients requiring bailout DES implantation. The proportion was 5.5%. And there was a similar number of patients who had originally been treated with paclitaxel or sirolimus coated balloons. This is the full list of enrolling centers. As I said, all of them were European, the majority were Italian. Then we had some centers in the UK, Germany, Switzerland, Spain, and Dr. Rissanen from Finland. Having a look at the baseline characteristics, of course, they are the characteristics of a contemporary PCI population with a mean age of 67. Females were 22%, only 1/3 were diabetics. We can see, very importantly, that bailout stenting was mainly required for de novo lesions with a proportion of stent restenosis of 11%, which is very low in a DCB cohort. And there were between group differences between patients who received paclitaxel versus sirolimus coated balloons. In the first instance, patients who received paclitaxel coated balloons were slightly younger, as you can see, had a higher prevalence of ACS presentation and lower prevalence of stent restenosis. So this again justifies our approach to do a propensity score adjustment when comparing these two subgroups. In terms of the angiographic characteristics, as expected, we mainly treated long lesions in this study. You can see that the median lesion length was 30 millimeters, but also that almost half of the treated lesions were located on large vessels as defined by a reference vessel diameter equal or higher than 3. 3 out of 4 lesions were complex, type B, Q, or C, according to the ACC and AAJ classification. And the main reason for bailout stenting was dissection in 62% of cases, followed by recoil or residual stenosis greater than 30% as the second main cause in 36% of cases, while the most serious angiographic complication which can occur, such as perforation, were quite rare overall. And you can see again that patients treated with paclitaxel coated balloon had a slightly higher lesion complexity with longer lesion length, larger reference vessel diameter, higher prevalence of bifurcations, and of also higher residual percent diameter stenosis after DCB angioplasty, all factors which were accounted for in the propensity score adjustment. This is the breakdown of the sirolimus and paclitaxel coated balloons employed in this study. The sirolimus coated balloons were essentially either the magic touch or the solution, while the most commonly used paclitaxel coated balloons was the sequence pleased by B. Brown. Now, let's have a look at the primary endpoint analysis, which was done at 1 year follow-up. As you can see, the incidence of MACE was 8.4%. and this met the non-inferiority to the pre-specified performance goal with a p-value for non-inferiority that was less than 0.001. The final population of 733 patients, importantly, provided us a 99% statistical power, so very high statistical power for to assess the non-inferiority for this endpoint. The incidences of target lesion failure and target vessel failure are shown here. They were 7% and 7.8% respectively. And here is shown the breakdown of the individual secondary endpoints, from which you can see that MACE was mainly driven by TLR, with an incidence of 4.1% at 1 year, and any myocardial infarction at 4% at 1 year, while the incidence of stent thrombosis was very low, less than 1%, 0.6% at 1 year. Here you can see the multivariable regression analysis for predictors of MACE at 1 year. After applying stepwise selection, we identified 4 variables which were independently associated with the risk of MACE at 1 year, and these variables were an ACS presentation, longer lesion length, moderate to severe calcification, and interestingly, the use of paclitaxel as compared to sirolimus coated balloons. And this latter result was also consistent, as you can see in here, in the pre-specified subgroup analysis using propensity score adjustment. What we found was that paclitaxel-coated balloons were associated with an almost 3-fold greater adjusted risk of MACE, with a higher risk of target vessel failure, target lesion failure, target vessel revascularization, and any myocardial infarction. The incidence of the other endpoints, the other secondary endpoints, namely target vessel MI, target lesion revascularization, was numerically higher in the paclitaxel group, although not statistically significant, while the incidence of stent thrombosis was extremely low and quite comparable between the two subgroups. We, of course, had some limitations in this study, which was an observational study, but I think it's quite early to expect a randomized trial specifically evaluating the outcomes of bailout stenting. Probably we will have that with the first subgroup analysis of the major randomized clinical trials, such as Transform 2 or Solution de Novo. And another important fallacy was that we started retrospectively enrolling our patients in 2011, so we had around 1/4 that were enrolled before the publication of the 3rd international DCB consensus document, which, as you know, defined the 2 indications for bailout stenting, that are dissection and recoil. So again, there were some procedures done in earlier times. And as I was mentioning at the very beginning, we decided only to include high volume centers of DCB PCI, and this might have limited the generalizability of the study findings, and in particular, underestimated the incidence of bailout stenting as compared to a real world setting. So in conclusion, these are the takeaways from this study, which was the first and largest to evaluate clinical outcomes of bailout drug-eluting stent implantation after drug-coated balloon angioplasty. As first, in this group of experienced centers, only 1 out of 20 patients required subsequent drug-eluting stent implantation, primarily due to flow-limiting dissection or recoil. When needed, bailout DS implantation in a DCB-treated segment appeared safe, and this was supported not only by a risk of MACE of 8% at 1 year, which was non-inferior to the pre-specified performance goal belonging to an upfront DS only strategy, but also by a risk of stent thrombosis, which was less than 1%, so very low. The finding that we had of a higher risk of most adverse cardiac events in patients receiving bailout stenting after paclitaxel as compared to sirolimus coated balloon angioplasty is definitely interesting, but I believe that needs to be considered as incidental and hypothesis generating at the current stage, as we had quite limited sample size in the 2 subgroups. But nonetheless, I believe this is something that needs to be evaluated in future randomized investigations. And this was my last slide. Again, I'm thanking even here all the co-authors on this important endeavor for their support. And I would be happy to take any questions.
Thank you very much, Dr. Gitto, for your comprehensive and very insightful presentation on bailout stenting and the critical role of the registries, as you mentioned. Your expertise and deep insights have truly enriched our understanding, and we are really grateful for your time and knowledge you have shared with us today. Thank you very much.
It's a pleasure.
Thank you, Mauro. Can you hear me?
Yeah, hi, Sandeep.
Perfect. Hi. So congratulations. It's a great study and very insightful, very hypothesis generating. I have one question to ask you. So you have presented paclitaxel and sirolimus coated balloons after receiving a bailout stenting, but the study duration ranged from 2011. Am I right?
Yeah.
So
Yes.
was the follow-up uniform or were they censored? Because as you can imagine, the sirolimus balloon came from 2016 or maybe 2017 in many centers, whereas paclitaxel we've been using from 2011. So when you looked at the clinical events in terms of the follow-up duration, did you censor the events at maybe 2 or 3 years so that you have more uniform follow-up? Because the follow-up duration in the paclitaxel will be longer, and hence maybe some of your outcome where there was a higher incidence of events in the paclitaxel coated balloon, maybe higher. Do you think that's the reason, or do you think you corrected that?
So yeah, actually we censored even for this reason all the clinical events at 1 year. The outcome analysis which we presented and which we also reported in the paper that is currently under revision is at 1 year for this exact reason that of course the median follow-up duration was 2 or 3 years in the paclitaxel group versus 1 year, 1.5 years in the sirolimus group. So we did only report clinical outcomes at 1 year, which I think is fair at the current status. I think it would not be informative to report extended follow-up from this cohort of patients. And I mean, we did a couple of further sensitivity analysis to confirm that these findings were not a play of chance. For example, we excluded all DCB procedures performed before the publication, before 2019, before the publication of the third international DCB consensus, and the results basically remained consistent. We also did some leave one out analysis by excluding some centers, and the results did still remain consistent. So I think that in this study population, there is no doubt that patients who received sirolimus-coated balloons went better than those who received paclitaxel-coated balloons. Of course, it's a limited population, and I would not feel comfortable calling it even a signal, but rather an incidental finding which will have to be confirmed.
So thank you. I think that censoring is very important. So I think that's very important to clarify. Now, second thing is that, yes, you say it could be incidental, but in your paper, when you written the paper, which is under review, have you proposed any potential reasons for this other than just saying incidental? Yes, it could be incidental, but one of the concerns obviously is that you have a paclitaxel drug and a sirolimus drug in one of the where paclitaxel receiving a limus stent, whereas sirolimus balloon getting a sirolimus stent may be more benign. Do you think, have you put that in? Because it's important because you got 2 drugs in one arm where you have paclitaxel and limus, and the other arm you just get double dose of sirolimus, which you can get with the stent they have from Concept Medical. What is it stent called? I forgot the name of the stent, but it gives you a DCB and a stent.
The abluminous stent. Yeah. So yeah, we speculated about the potential causes in the discussion while keeping the tone as hypothesis generating, and this is definitely one of the main hypotheses of the interaction between different drugs, paclitaxel on DCB versus limus derivatives on stents, and this hypothesis is also supported by some work which were done back in time with paclitaxel-coated balloons combined with bare metal stents, which proved to be did not prove to be non-inferior to tracheolytic stents because there was a higher risk of adverse events in patients who received a bare metal stent after paclitaxel coated balloon angioplasty. This was done, I think, around 10 years ago, but I think it can be related to our findings as well. Another explanation, which of course is again another hypothesis, but I think is very, very interesting and their conceptual point of view, is that we know that paclitaxel can provide late lumen enlargement in some cases. So there might be an issue of stent malapposition, which emerges in the long run. And I think this is probably the hypothesis that intrigues me the most. We also looked at the Kaplan-Meier curve of the events and of the EMI events to exclude that some of these events might have been due to the distal embolization of paclitaxel coated balloons, because maybe some centers reported periprocedural MI, but actually we found very few periprocedural MI, very few MIs occurring in the first days after PCI. So I think this was not a contributing factor. So the hypotheses we provided were basically the first two: the interaction between different drugs and late lumen enlargement provided by paclitaxel coated balloons.
Any difference in the scaffold stent thrombosis between the two groups?
Well, actually, there was like 0.8 versus 0.4%, which I think is not meaningful because, as you know, stent thrombosis is a very rare event, and thankfully the incidence was very low in this cohort. So you would need tens of thousands of patients in order to.
0.8 in the paclitaxel and 0.4 in the sirolimus.
All the endpoints were numerically higher in the paclitaxel group, but again,
that makes sense.
Especially for stent thrombosis. But
malapposition
especially for stent thrombosis, this is a couple of patients of different, but it can be related to malapposition. Yes.
Perfect. Thank you so much.
Thank you, Mauro, for your elegant presentation and your very impressive data. I have two questions. First of all, do you find a difference in bailout rate and prognosis between patients who underwent treated with or without intracoronary imaging? And second, if this data will be confirmed in the future randomized trial, do you think that this data can impact our clinical practice? Thank you.
Thank you, Filippo. These are actually great questions. So first of all, unfortunately, we did not have data on patients who did not undergo bailout stenting in the same centers during the same enrollment period. So we could not make comparison on the use of intravascular imaging. That being said, the prevalence of intravascular imaging use was as low as 10% in this cohort, which is of course in line with the real-world PCI. But we are definitely allowed to say that the use of intravascular imaging did not lead to a higher prevalence of bailout stenting. The other question about the impact of these findings in terms of future clinical practice, if these were confirmed by randomized clinical trials, I think the answer is definitely yes. If such, I don't know if there will ever be a randomized clinical trial comparing sirolimus versus paclitaxel coated balloons in the novo coronary artery disease. To my knowledge, there is no such at this moment, especially in terms of large trials with power for hard clinical endpoints. But if there was such a difference, even in the specific subset of bailout stenting, I think it could be very clinically meaningful, because for a center which starts to perform DCB-based PCI, the likelihood of ending up with a bailout stenting has to be taken into consideration, right? The operator who's performing his first DCB case, you want to have the safety that if something goes wrong, you can place a stent and terminate the procedure safely. And actually, this signal that the interaction between Limus eluting stents and sirolimus coated balloons is more favorable than the interaction between paclitaxel and Limus. If this is confirmed, I think this could be really a good pro when choosing between sirolimus and paclitaxel coated balloons.
Thanks, Mauro. Great presentation. I have a question for you regarding the rate of bailout stenting and the evolving rate during the years. Meaning, I think that one of the best things of this study is that you decided, I think this is the best things, to involve all experienced center, not to have a real world data regarding the real rate of bailout stenting, because probably we should treat DCB angioplasty as a specialistic things, like for complex PCI or CTO. So my question is, do you think we should accept this rate, meaning it is an intrinsic limit probably of the DCB angioplasty, or we can more improve during the years this rate of bailout stenting? And 3 advices that you could give regarding the reduction, probably during the years, the bailout stenting rate, but with an optimized result after DCB angioplasty. Thank you.
So at the current stage, I think that we should try to avoid bailout stenting as much as is possible. And an interesting thing that we observed when comparing our centers, which, as I said, were all quite experienced centers, but of course there were some centers with higher volumes than other, and the proportion of bailout stenting changed significantly among centers. There were centers which did 1 or 2% of bailout stenting during the study period, and others who did 10 to 20%. So I think it's all about a growing experience with the use of this technology. So at the current stage, what we should target is 0 in terms of bailout stenting, and of course it's a very high bar, and I think 5% is quite unacceptable, right? Let's not forget that in the REC-H3, the rate was double than the one that we found in this registry, and they used to treat only focal lesions. So I think these results are quite good for the centers that were involved. At the current, I would say at the current time that we should try to avoid bailout stenting, but again, this interaction between DCB and DS needs to be further evaluated, and maybe it might turn into something favorable as well. There was someone in the panel during my presentation at PCR who suggested whether this finding could impact future research, for example, on a so-called dual therapy for more complex coronary lesions, in which you give both a DCB and a drug-eluting stent in order to further suppress the neointimal hyperplasia and the atherosclerotic progression. So that can be something which is worth investigating, but as of now, I would say that we need to avoid that. Yes.
Thank you, Mauro.
It's almost considerable as I don't like the word malpractice, because I think there are worse ways of doing malpractice, but still not optimal practice. Let's call it not a suboptimal practice.
Thank you. Oh, please.
Thank you for the great presentation. Just a quick question regarding maybe I missed that, regarding the duration of the depth. Was there any difference between the 2 group, or wasn't even?
Actually, I think I didn't show this in these tables, in these slide tables, but we showed that in the paper, and there were no differences, and the DAPT duration was the standard one, between 6 and 12 months, based on the clinical indication. At the current stage, unfortunately, I think not so many centers perform short DAPT after drug-coated balloon angioplasty, and actually we don't have clinical data supporting that. So.
Thank you again. Congratulations on this work.
Thank you so much.
Thank you very much, and also thank you, Dr. Filippo, for organizing this session. It was a very interesting joint session. Thank you both. We learned a lot, and thank you everyone for participating. If there are no other questions, maybe we can conclude this session. It was a great pleasure to have you, Dr. Gitto. Thank you.
Thank you so much. It was my pleasure to be here. I think it was very, very interesting and constructive, the discussion. So I will be happy to be involved again whenever you want.
Thank you very much. It would be our absolute pleasure. Thank you. Have a great evening.
Bye.
Thank you. Bye.
Thanks, Mauro. Thanks, guys. Have a good day.
Thank you.